at Shaukat. He is particularly interested in cancer, and he's going to talk about kidney cancer. So I'm really grateful for him to come as the first speaker of 2021 in the conceptual basis of urology course. It's going to be highly interactive, and please have your question posted on the chat box, because Dr. Cheema will be available to take your questions. And as the question comes to your mind during the presentation, or you have any comments, please post them on the chat box, and they will be addressed during or after the session. So let's, without wasting any further time, let's go online. We have good participants. So Dr. Cheema, your presentation is live now. Okay, please start, Sharif.
Good evening, everybody. This is Zubair Cheema, consultant urologist from Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. Firstly, thank you very much for inviting me to give this talk on this forum, which is basically a webinar series covering the conceptual basis of the urology. The topic which I'm going to talk about today is renal cancer, an overview and case-based discussion. Now, this is such a huge topic that it's simply not probably possible to cover it in its true spirit in one talk. But what I've done is to cover some basics of this topic so that we all have a broader view of it, try to touch a majority of it in this talk, and then combine it with some case-based discussions at the end. So feel free to put any comments in the chat box, ask any questions, and I will try to answer them as we get along. So this place on the right is where I used to work a couple of years ago before moving back to Pakistan, and the one on the left of the screen is the Shaukat Khanum Hospital, Lahore, where I'm currently working. I don't have any disclosures to make for the purpose of this talk. Majority of this talk is based on EAU guidelines, 2021 version on the renal cell carcinoma. So if we look on the epidemiology of the renal cancer, just to give you some idea that over the period of years, the incidence is rising. I mean, this data is Cancer Research UK. Unfortunately, we don't have an established national registry, and this is something which I keep talking about in various meetings. Probably it's about the time that we get a national registry here in Pakistan. We all work together, put our data in, so that we can have some meaningful discussions when it comes to the data and research. Anyhow, you can see based on this data from the UK that the incidence has been steeply rising and then kind of plateaued back in 2018. The reasons of this rise, steep rise down there, are difficult to say, but maybe you can say attributed to increased use of the imaging. So finding more of the incidentalomas may be one of those reasons. Moving on to the etiology of the renal cancer, the known risk factors, as is the case for most of the malignancies, smoking is well known related to renal cancer. Other factors also include obesity, hypertension, and family history. Various studies have shown some protective factors, which include physical activity, eliminate smoking, and reducing weight. So if we talk about the various types, histological types of the cancer, the most commonest form is the clear cell carcinoma. You can see some clear cells in the slide here on the left of the screen. These are clear cytoplasm arranged in the nests. In the chromophobe RCC, which you can see the cytoplasm is probably filled with some colloidal iron in that. And then the papillary type 1 and the type 2 carcinoma, the type 1 where you see the cells with the fine cores, and the type 2 where you see more eosinophilic cells and macrophages in both of them. Collecting duct carcinoma is more of an aggressive form of the cancer, though not too common you see more of the tuberocystic structures under the microscope. AML, one of the benign entity, is composed of blood vessels, fat cells, and the spindle cells, as the name suggests. Although it's a benign entity, but sometimes it can be difficult to diagnose purely on the imaging, especially in the fat poor AMLs. You may end up taking the kidney out, doing some kind of surgery, and it turns out to be AML. So I certainly have come across it a few times. Oncocytoma, the challenging one in terms of the diagnosis. At times, cut surface you can see shows a mahogany brown surface with a central scar. Not all the time you see it, but sometimes it's quite diagnostic on the imaging. And the cells are more of in the form of solid nests. We all know ongoing debates in our MDTs at times when we're not clear purely on the imaging, is it oncocytoma or not, should we take it out or not, how it behaves, especially in the young people down the line, oncocytic variation of the tumor in them, or can the cell behavior change over the period of time. These are all debates we have all come across at various stages of our career. Then is the majority of the renal cell cancers are sporadic, but we do come across the hereditary ones. So what kind of hints towards the hereditary? If there's a family history, early age of onset, and if you see any other lesions in the body. So think about hereditary conditions, more commonly the VHL syndrome, right? You see cystic lesions in brain, in pancreas, kidneys, epididymis, hereditary papillary renal cell carcinoma, Brit Hogg-Dubé syndrome, named after the 3 Canadian doctors, where you see the skin lesions as well as the lung cysts can cause pneumothorax in some patients, hereditary leiomyomatosis, renal cell carcinoma, and conditions like tuberous sclerosis. So yeah, be aware of these conditions as you come across them. TNM classification, again, as per EAU, T1 being tumor less than 7 centimeter, limited to the kidney, again, further divided into T1A and B, depending on the size. T2, again, limited to the kidney, but more than 7 centimeter. And then comes T3, in which T3A being segmental vein or the renal vein involvement, or the sinus fat involvement. T3B, if it's grossly extending into the vena cava but below the diaphragm. T3C, if it extends into the vena cava above the diaphragm, or it invades the wall of the vena cava. T4 obviously going beyond the gerota. And N1 is metastasis in the regional lymph nodes, and M1 is a distant mets. So once we suspect a renal mass in a patient, so what kind of imaging you're looking at in terms of your investigation? See, I think the CT is pretty much the gold standard, a dedicated triphasic CT scan with a non-contrast phase, arterial phase, and portovenous phase to see define the mass is considered gold standard, obviously, if there are no contraindications. And then you compare the lean in terms of the contrast uptake and see the difference in Hounsfield units between the non-contrast and the contrast CT. And if it's more than 15, then obviously the suspicion gets high. It's important to give that variable question to the radiologist before requesting a CT for these patients, so that they do the really dedicated scan, which also helps you in terms of surgery, especially if you are trying to look at the vasculature of the kidney to plan your surgery. MRI, obviously, if there's a contraindication to do a CT scan, MRI can be considered. Some contrast enhanced ultrasound have some value. CT angiography, again, as I said, especially in planning your surgery, is very important. Imaging is getting good day by day. So renal biopsy, again, touching, it's again a topic where you can have a very lengthy, detailed discussion on its own. Once you have found a renal mass, I mean, unlike some of the other cancers, if the radiological evidence is good enough to say that this is tumor, cancerous tumor, then usually we tend not to do renal biopsy and we go for upfront surgery. But obviously, there will be certain scenarios we all have come across where we feel more comfortable by doing the renal biopsy first. Obviously, one has to weigh those pros and cons and consider the complications of the biopsy. It's at the end of the day, it's an invasive procedure. So some of the reasons it's being done is usually for active surveillance for small renal mass in the fitter patient. So you really want to know what you're dealing with. Before ablative therapies, yes, it's wise to have a renal biopsy done. In certain metastatic conditions where you are planning to give, in certain metastatic renal tumors where you're planning to give a um, um, some adjuvant therapy. So you may want to have a renal mass biopsy or a metastatic lesion biopsy, whichever is suitable. And then there are some special scenarios, and probably we'll come to that towards the end of this talk. In one of the cases, um, uh, whenever we do biopsy, I do tell the patients that there's a fair 20 up to 20% chance of the biopsy being false negative or not conclusive. So one has to make up your mind that if that happens, what are you going to do with that mass? Okay, so you need to have that frank discussion with the patient, that yes, we are going to do the biopsy, but what if it comes false negative? Are we going to leave this, whatever that mass is, in the tummy or not? So that frank discussion needs to happen. Patients do ask, is there any risk of spreading the tumor, or after doing a biopsy? I guess they're referred to the seedling. The chances are very slim now because of the modern techniques where they use usually 18 gauge needle and the coaxial technique. So well, in terms of management, so yes, once you have established there's a renal mass, you have done the required staging, which especially includes the CT chest, especially in larger tumors. There are studies which have shown that if the tumor are smaller, say T1A, then there's not particular need of doing a CT chest. So you can get on with the only chest X-ray. But the larger tumors, once you have established the diagnosis, we do a staging scans, and then obviously you divide the tumor into either it's non-metastatic or metastatic. So if it's non-metastatic, either you have a larger masses or you've got a small renal masses. For the larger masses, the mainstay of the treatment is surgical unless the patient is not really fit for it. But small renal mass, there are quite a few options, and those options obviously depends upon patient factors as well as the surgeon um, uh, uh, factors, and sometimes at times patient choice. Mainly surgical treatment options in terms of the partial nephrectomy. There are ablative therapies, RFA and cryo. There's the option of surveillance, and obviously there's a watchful wait. So one has to, if we talk about partial nephrectomy first, which is a surgical treatment of the small renal mass, say the mass less than or around 3 centimeter. There are few indications are divided into absolute, relative, and elective, purely elective. So absolute indications include if somebody has got a single kidney, single functioning kidney, or anatomically single kidney, and excuse me, and there's a small renal mass, the right thing probably will be to go for partial nephrectomy if it's suitable to do so. Bilateral renal tumors and significant renal impairment are the other reasons. Relative, and there's a potential abnormality with other kidney, say stone disease, or there are metabolic risk factors, say somebody is diabetic or hypertensive, and you kind of foresee that probably down the line this patient is going to have some kind of trouble with the renal functions. It's better to save nephrons. So yeah, consider partial nephrectomy. Elective, yes, small tumors in the young patient, although they may be fit and well now, but they've got a longer life expectancy, and subjecting them to the radical treatment may not be the right thing. And similarly, anatomically suitable large tumors. So yes, the tumor may be large, but it may be hanging off of one of the poles of the kidney. So technically, it may be suitable to do the partial nephrectomy. So why not? There are different nephrometry scores being used before you embark the patient into the partial nephrectomy. The idea of all these scoring system is kind of plan your surgery, right, or plan your day, so you can expect how you can plan, like how difficult your procedure is probably going to be, right? So this is the example of the renal score. okay, the complexity is low, medium, and high. Like this is what you're going to face probably during the procedure. Low scoring is 4 to 6, 7 to 9, medium, and 10 to 12 high. And how they've worked it out is depending on the radius, maximum radius of the tumor, and then they have given it a score, or depending on the size and centimeters. Is it majority is exophytic or majority is endophytic? Then you get an appropriate score for that. A nearness to the hilum, how close it is to the hilum. Is it interior, posterior, and location in terms of the polar lines? These things help in planning, and planning is very important doing um, any surgery, but more so doing partial nephrectomy, because it's just one of the fairly complex surgeries in urology. So in terms of the techniques, it depends what facilities and what skill set you have got. There's open partial or nephrectomy, open partial nephrectomy. There's a robotic assisted per lap partial nephrectomy. There's a pure laparoscopic partial nephrectomy or a hand assisted laparoscopic partial nephrectomy. If you see in majority of the world, either it's the open partial nephrectomy which is practiced, or robotic assisted partial nephrectomy being practiced, because with the introduction of the robots over the last few years, um, the surgical skill set is getting better and better, and is much technically easier with a better control compared to the pure lab, which is getting less and less. So I think the majority of centers are doing either open or robotic assisted, especially in the West. Here we are doing some suitable cases, pure laparoscopic partial nephrectomy in our center, but that's because, as I mentioned, that we don't have a robot here, so either we do open or laparoscopic, depending upon the kind of the tumor we're dealing with. Uh, when again, as I said, planning is very important, and as we mentioned earlier, the imaging techniques are getting better and better. So before embarking on partial nephrectomy, it's always valuable to sit down with your radiologist and go through the images, to kind of know the location of the tumor, the vascular supply of the tumor, and they can all reformat those images for you at times, to create some fancy images so you can plan your day better. And there are 3D models getting popular, where you can kind of practice your surgery even before the actual day, or see what your potential problems you're going to have. So these fancy techniques are getting better and better day by day. At the end of the day, the aim is to achieve what we call as a trifecta, which is a negative surgical margin, so no compromise on the cancer. The aim is to preserve the renal function, so ischemic time less than 25-30 minutes, and no intra or post-operative complications. So that's the mainstay of using this technique. I mean, these are the images of one of the patients which we did quite recently. A youngish guy, and probably in his late 30s, presented to us with some kind of abdominal pain, and then later on scans revealed uh, approximately 2.5 centimeter tumor, which was kind of posteriorly located on the right kidney, in the mid lower pole. We managed to do it laparoscopically, and he did pretty well after the surgery. So if we look at the EAU guidelines in terms of the oncological outcomes, comparing the partial nephrectomy and radical nephrectomy, and I think that's one of the questions we always ask, like, why do partial, why not radical? So the oncology outcomes in terms of overall survival are similar, and there are retrospective studies suggest that oncological outcomes are similar following partial nephrectomy versus radical nephrectomy in patients even with the larger tumors. So it's not just the small renal masses, even the large masses which are suitable to do the partial nephrectomy still do equally good, but the complications may be higher in partial nephrectomy group. Uh, Another interesting comment, do not perform minimally invasive radical nephrectomy in patients with T1 tumors for whom a partial nephrectomy is feasible by any approach, including open. So uh, uh, that's quite interesting. So if, say, you have got a patient where with a small renal mass, a small tumor, where either he can have a minimally invasive, say, laparoscopic radical nephrectomy, but say you don't have a robot, or the partial nephrectomy will be open with a bigger cut, with a morbidity. But the recommendation is that for those tumors it's better to preserve the nephrons if they are if there's a right indication for that. Now, obviously, in a certain cohort of patients which are elderly, right, and may not have a significant comorbidity, so you can also have an argument why give them uh, a more morbid open operation, and why not do a simple, straightforward, minimally invasive laparoscopic radical nephrectomy, especially when they're in the later stage of their life, but they're still fit enough. So I think there can be a fair bit of debate on that point, and this will vary from case to case, and depending upon where the tumor is and how difficult the open partial can be. And bear in mind, that's where the MDT kicks in, and you have exchange of ideas at the so as far as the active surveillance is concerned, the point to tell the patients, which is very important, that the growth of those small renal masses is usually low. And these are small masses less than 3 centimeter in size. Their progression and metastatic disease chances are only less than 1 to 2%. So yes, this is the argument going in favor of the active surveillance. However, obviously, if you've got a frail and patients with significant comorbidities, you can offer them thermal ablation or watchful waiting. I think at the end of the day, you have to choose the right patient for the right treatment, right? One shoe will not fit everybody, right? Um, Active surveillance is suitable for younger and patients who may not want to have surgery at that stage of their life, but that they're amenable to all the treatment options available. And it's very important that they understand the meaning of active surveillance. They know what they're choosing, what are the potential risks involved, or what that pathway of active surveillance entails, right? So it means coming to the clinics at a regular interval. It means having a regular scans and maybe a potential impact of those scans in their life, right? But if they are okay with that and the lesion is small, that's what they choose, sign up to. Uh, Ablation, cryo RFA, I mean, the lesion obviously needs to be amenable to ablation. You should have the facilities in your center to do that. Usually it is reserved for more of a unfit patients, or if the lesion is too small. On a watchful wait, again, this should be clearly communicated to the patient. This should not be confused with active surveillance. Watchful wait is that you are telling the patient that due to the other significant comorbidities or other things, you are just keeping an eye on this lesion to become symptomatic. And if it does, then you deal with the symptoms, right? You're kind of drawing a line on the treatment. So I've come across a few times when some people confuse this with active surveillance. This is not active surveillance. This is watchful wait. Okay. And that's where the MDT helps. I say again here, because choosing the right patient for the right treatment, it's always worth to have opinion of your colleagues and get their expertise involved and see what they think. So that's where the MDT decision kicks in. Then we've got the locally advanced tumors, say with a nodal disease. So as far as the literature is concerned, a majority of it says that lymph node dissection has more of a prognostic value. Uh, so uh, rather than overall survival, there will be locally advanced tumors in terms of the tumor thrombus, which is another challenging situation which we do come across not very uncommonly here. And then it depends about the other metastatic load, if there is any, and you need to have certain expertise available to you to deal with these cases. And that's where I want to show you this picture. You can see the renal thrombus going just flush with the IVC here. Then level 1, which is subhepatic, level 2 going into the liver, level 3 is just above the liver, and level 4 going above the diaphragm. Now, these are challenging cases. These needs proper planning. You need to have the right skill set. You need to have the right expertise of the other team, say the vascular team, and the right equipment available to deal with these cases. So in terms of the metastatic renal cancer, there has been several trials in the past, Carmina trial and the SERSAM trial, and the introduction of the interferons in the past, and then tyrosine kinase inhibitors. But I think more recently, the recent trials have suggested that all these patients need need a proper workup. And one of the models which we use here is IMDC, where we look at the patient's performance status, interval from diagnosis to treatment, hemoglobin level, corrected calcium level, neutrophil count, platelet count, and then you score them accordingly. And more recently, the evidence is that if they score more on them, more than 2, then the role of cytoreductive nephrectomy becomes and less and less. Unfortunately, we see quite often young patients here in this part of the world which come to us with the metastatic disease, and sometimes you just have to carefully select them before offering them surgical treatment, and these models help us. Um, Once the surgical treatment has been done, the follow-up is usually in terms of the imaging, which is a combination of either a CT scan or MRI scan, depending upon the any contraindications. We divide the patient into low risk, intermediate risk of recurrence, and high risk of recurrence, and then do the scan at 3 monthly, 6 monthly, 12, 18 monthly, and then onwards as per EU guidelines. That's what I follow. And the way we put them in these groups are for clear cell Leibovitz score, and for non-clear cells, you look at their histology and PTN staging. And this is a Leibovitz scoring system, which looks on different um, factors in terms of the tumor necrosis, fat invasion, margins, and then you give them a score. So it's pretty handy to use it. So I think let's move on to a few of the case-based discussions and see what we think about them. So the first case I'm going to talk about is about a 27-year-old man who was previously fit and well, presented with a headache, vomiting, and some generalized body symptoms. He did not have any abnormality on the hematological or biochemical workup as a part of his imaging. That's what his CT scan showed. So I will let you spend some time to look at them. There are only a few slices of images which I can put it here for the purpose of this presentation. Obviously, ideally, I would like to show you the whole film. So what do we see on the left side? We see a bit ugly looking mass here or anteriorly, and then another one behind it posteriorly. Again, another lesion here, another one lesion here, and one here on the left side. So, and on the right side again with IF beliefs, you see a lower pole lesion here, another one here, uh, and one here posteriorly. So please put it in your comments. What do you think is potentially going on? And then I refer back to one of the initial slides, which I showed you. What would you like to ask this patient about? Any other symptoms and any family history? So the first thing which comes in the mind, yes, looking at the scan, that's not a good news for the patient. But equally, it's not a great case for a physician either. I don't feel any better when I see the scan. I know this patient is in trouble. He's got bilateral renal lesions. He's got some underlying condition leading him to that, which obviously needs workup. He's probably going to be with us for quite some time, quite some part of his life. He will probably need multiple surgeries or interventions. He needs detailed counseling and then planning of all those steps, which is not easy. These are not easy discussions, but I'm afraid that's what it is. So what helps? MDT helps. Um, um, Again, coming back to that point, sitting together with the other colleagues of the department. Some of them might have again seen this more often than you as a younger consultant, sitting down with your radiologist to go through those images again and see which lesion, how can you tackle that, which part of the kidney is involved more. Can you do minimally, can you do nephron sparing surgeries? Can you do ablative therapies? Because these patients will keep on forming these lesions. So these are challenging cases. Do not take them easy. And I think the emphasis here is that you plan them well and you counsel them well. You tell them upfront about their condition, about the path they are going to embark in future, obviously in an empathic way. Need to involve other specialties like nephrologists, because this patient will end up needing their help. As I said again, seek help. Don't feel shy about that. So I think this particular patient had a radical nephrectomy on the left side, and then the ablative therapies on the right side of the smaller lesions. I think he's been out with us for a couple of years. He's doing okay. He had a VHL syndrome, as you would have guessed already, I believe. Another case of ours, 55 female, hypertension, no previous surgeries. Presented to the local facility with abdominal pain. Again, blood parameters are okay. Had an ultrasound and then further imaging. So feel free to put your thoughts about this, Leon, and see what would you like to do with this patient, what kind of surgery she's heading to. Okay, so what I can see is a pretty ugly looking lesion involving most of the left kidney. The right kidney looks fine. Again, whenever you're planning of surgery, again, see all the slices which are not here for the purpose of this talk, but see how much fat is there outside the tummy when you're thinking about going in, how much fat is around the kidney. Is there a sea of fat? What the hilum looks like? What is the surrounding fat stranding or new vascularization there? How many arteries are there? Is there any more than one artery, more than one vein? And so all those things needs to be put into account. So treatment options, what do you think treatment, what could be the approaches? And are there any red flags? Looking at the scan again, so yeah, this what the scan is. So you, uh, treatment options, I think the treatment option for her was surgical approaches. Yes, she can have an open radical nephrectomy. She can have a laparoscopic radical nephrectomy. Again, all depending upon the expertise available. Are the red flags? Yes. I mean, when I see them, large layers always make me worry, because there's usually a lot of new vascularizations associated with them. So think about it as you saw in this scan. And especially this was mid upper polar tumor. So they get sometimes the adrenal involved, and especially if you're doing the left side laparoscopically, even if you're taking the hilum down, I always say until the adrenal is not done, especially on the left side, the surgery is not over. You may feel relieved that you have taken the hilum down and you are now sailing back, but that's not the case. You have to be careful when you're doing the adrenal, because that can go a long way up, and there can be a lot of new vascularization, and sometimes the large tumor can push the spleen up, so there's a long way to go there. So yes, be mindful of those things. uh, Next one, 28 female, um, fit and well, abdominal pain, again no abnormal parameters on the blood. um, So that's the scan. Let's have a look at it, see what you think of it. Um, um, Feel free to type down what you think could be the potential problem here. I can see a big mass here on the right side. There's left kidney there again on this particular slice. Excuse me. Can you think about any other issue which can potentially there? Okay, let's make it a bit more simple. Yes, you can see. Excuse me. You can see tumor thrombus going across the renal vein into IVC. Right. So you got this case. So what do you think um, could be the problems here? How would you plan this case? Who would you involve? What will be at the back of your head? What kind of approach you are going to have? What kind of incision you are going to make? Um, who else will you need with you in theater? So have all those questions answered, well talked about, thought about before going in theater with this patient. Obviously, she has got a vascular involvement, so yes, she needs a nephrectomy, but she also needs IVC thrombectomy. So you will be dissecting the IVC up and down. You probably will be going across on the left side to have a control of the left renal vein. You would like to have, especially if you're early on in your career, a senior colleague with you, or maybe on a standby with you. You would definitely like to have a somebody with a vascular expertise or a vascular surgeon with you when it will come to the clamping of the vena cava and opening it up to remove this thrombus, controlling it at the top of the thrombus, inferior vena cava control, and the left renal vein control. And sometimes there are big juicy lumbar veins which feed into the renal vein even you have clamped the other three, and the blood flow comes from there. And not to forget your anesthetic colleague. You have to uh, be kindful to them, to tell them before this case comes to theater so that they can adequately prepare them. They can have all the necessary lines, all the products available to them. And when you clamp the IVC, you give them a prior notice. So again, I'm re-emphasizing those words: planning. Planning is very important in these cases. Teamwork, yes. You're not the sole hero here. You need your team to be the hero here. You need your colleagues to come up and help you. Be clear about the steps of the operation. Have a plan A, plan B, well talked about. And these will be the key messages. Yeah, we did her along with our vascular colleagues here who helped this case with us. You can see the kidney has been taken out. There's a IVC defect when we remove the thrombus, and that has been nicely stitched. There's a left renal vein going on there. So that's what it looks like afterward. But these are big surgeries, and please do give due respect to them. Right, let's move on to another case and make it bit more interesting. 27 female, no comorbidities. She's 15 weeks pregnant. She had one child who is currently 3 years old. She had a miscarriage 1 year ago. She had a routine ultrasound as part of pregnancy, which found a right renal mass. She has come to your clinic. She is tearful, obviously. She has reasons to be tearful. So what do you think? What imaging will you do next? Can we do a CT while she's pregnant? Can we think about some low dose CT? But it'll be less harmful to the fetus. Contrast enhanced ultrasound or MRI scan. If you're not sure, ask your radiology colleagues. Have a discussion with them. I think we went on with the MRI scan being so that no radiations are involved. And what did the you can see the image here, an ugly looking mass in the right kidney. Probably it was around 6 centimeter, involving most of the mid pole and extending medially here. The report said it's a large lobulated renal cortical tumor with imaging features concerning for renal cell carcinoma. So that's what you have got based on that report. So obviously, this is a challenging situation because it's not one life at the end of the stick here. There are two lives involved. She has got this ugly looking mass, and she has just started her second trimester, meaning there's still another 6 months before the pregnancy comes to some conclusion, and then some time to recover. So what could be your thoughts? Can we have a period of surveillance for her? Should we be embarking surgery? And if we do embark surgery, should it be partial? Should it be radical? So please feel free to write down some comments on that. What do you think of this case? And how would you approach it? What would you do out of these three, and why? So while you're doing it, let's put the scan back up and have a few more moments to look at it. Now, but while we're looking at it, I mean, obviously these patients are quite emotionally upset, and they've got the reasons for that. This is not a pleasant scenario to be in. So again, if you have decided for surgery, and I would tell you the reason why. I mean, why I haven't put surveillance. And the reason, it's a 6 centimeter tumor, or a cancer-looking tumor, and which is bit big, and she has got at least 6 months of pregnancy, and then maybe another month to recover. So personally, I don't feel comfortable leaving it for 7 months in a young girl, because if it is something aggressive, then you're risking mom's life as well. So I think something needs to be done. But if something needs to be done, do we need to do anything before the surgery? And that brings me to the role of biopsy in this case. And that's what I was referring to in one of my initial slides, special scenarios. Would you do biopsy, or would you be happy with your radiologist's confident report that it's a renal tumor, it looks like a RCC? So feel free to answer yes for biopsy or no for biopsy. So I think what we decided in this case, that yes, we went for biopsy. I think the reason we went for biopsy, that I really wanted to make sure that this is a tumor we are dealing with, because we know that even when radiologically looks like a tumor, there's still a good 20% chance that it can be a benign tumor, right? And that's the last thing you want to have, especially in somebody who's pregnant, risking the mom's life as well as baby's life for a benign tumor. So yes, I think we had MDT discussion on it, and we went down for biopsy. Obviously, it's important to liaise with obstetricians so that the right scans have been done. Mom has been counseled. In this particular case, if I remember, this particular case, the biopsy did showed cancer. The timing of operation is very important, because the second trimester by far is the safest trimester to operate. If one has to, there are still risks. Counseling, spending time with the patient and the partner is very important. You need to tell them why you are doing it, what are the risks to the mom if we not do it, what are the risks to the mom and the baby if we do it, right? So it should be clearly black and white told to them, as well as clearly black and white documented in patient notes. These are again not easy. So second trimester, as I said, is the safest period if one has to operate. We admitted her a day before the surgery. We did an in-house fetal well-being scan to document the status of the baby. We did a laparoscopic radical nephrectomy. She did pretty well. It turns out to be a chromophobe renal cell carcinoma. So I've tried to cover some aspects of the renal cancer in today's talk. I'm sure you'll have some bits to pick up from there. But one of my bosses used to tell this to me, and I felt like that I must put it down here for the younger trainees and the younger consultants. As a surgeon, you do not become wiser once drapes are on, and that's very important to remember. You have to have your homework done before the day of the surgery. You have to have your planning done before the day of the surgery. You should have a plan A, B, and C actually rehearsed in your mind before you walk into the operating room, so that there's no looking back again. You're not going to become wiser once the drapes are on. So that if you have to take something out of this talk, I would really like you to take this thing away, definitely. So thank you very much for giving me the time to have this talk on this topic. I'm happy to take any questions or comments, if any. Thank you very much.
Thank you very much, Dr. Cheema, and I think it's a wonderful talk. You have provided a good overview of the basics of kidney cancer, and with the case-based discussion, the application of that knowledge provides practical value. So there is a question from Professor Ataur Rahman that why not consider a partial nephrectomy Before Dr. Cheema can address this question, my personal bias that if you do it during pregnancy, I probably would do a more straightforward surgical procedure like a radical nephrectomy in a 6 centimeter midpolar tumor. However, if she decides not to get the surgery done and it is done after delivery, then I think there is an indication for doing a partial. Zubair, what do you think?
Can you hear me, Prof. Ahmad?
Yes,
Can you hear
yes,
me?
yeah, we like.
Right.
Please go ahead.
I think I quite agree with you. I think it's a difficult situation. It's a challenging situation. Probably for this kind of a tumor, if I would rather go for a relatively straightforward, simple procedure, right, with this kind of tumor, rather than more morbid. And then again, which point which I emphasized earlier, it depends what expertise do you have available to you, right? If you're going to do a difficult open partial nephrectomy, that probably is going to put more strain on the mom and maybe on the baby, and similarly a longer recovery time. So hence that was the reason for going for lap radical nephrectomy, especially with that kind of size of tumor. So another comment, I think, like we have really done it for 6 or 7 centimeter tumor, should we have waited for the pregnancy to be over? Again, I think it's open to debate. I'm not sure if there's enough data on that to tell what exactly to do, but leaving 6, 7 centimeter potentially aggressive tumor for another 7 months is not something which I will be comfortable with. I'm open to opinions of the other people.
Okay, so I think the data
sorry, just one more comment. Just one more.
Yes, please go ahead.
And I think there's a comment, then why not do another 3 monthly or 2 monthly scan? Okay, fine. But the issue here is that whatever you have to do in the second trimester, right? Because that's potentially the most safest window, right? So if you're thinking about, okay, she has started the second trimester, you're going to repeat the scan in 2 months' time, and it has gone bigger or looks more uglier, then you are already into third trimester. Your hands are tied. So it's not, there's no win-win situation here.
Yeah, I quite agree with you. There's a question. I think I'll come to that point about leaving a 6 centimeter tumor, and the data. The data is there for smaller renal masses. 1 to 2 centimeter, very low potential for metastases, almost 0%. 2 to 3, it increases to about 10%, and then after 3 centimeters, there is a significant potential for metastasis. Now, this starts off at nearly 15 to 20%, and then it keeps incrementally going up and up. The point about biopsy, I think that adds an advantage, because if you identify more than one adverse pathological feature in the biopsy specimen, your chances of increase incrementally. So 2 or more than 2 adverse pathological features makes it a bad tumor. So those definitely would require earlier action like surgery during pregnancy.
I think I agree about the points what you have emphasized. But again, these are difficult cases, and there may be a different of opinions here.
Yeah. So Dr. Khanum asked if it is a chromophobe, would you consider waiting for a while? So I think just going on to that point, that the kind of tumor also dictates what are the propensity of developing a metastases. So Zubair, what would you have done if it comes out to be a chromophobe?
Right. Okay. I think that's interesting, and that depends how confident your pathologist is on that core of biopsy. So majority of times the discussions revolve around whenever we sit in our MDTS. Sometimes they're pretty confident this is chromophobe. Sometimes they also kind of like to play kind of on a line on the edge and say that it is suggestive of a renal cell cancer, right? Could be favoring chromophobe or could be favoring RCC, right? So yeah, if it's chromophobe, yes, it's less aggressive. If you're confident about it, yes, you can think about a period of surveillance or wait. When you say surveillance, it's essentially 7 months you are talking about, right? So you can make a point for that, and you can counsel the patient accordingly, right? So yes, probably you can do that, but how confident on that core biopsy histology your pathologist is, that remains a debate. Now, if it's oncocytoma or benign, it's conclusively benign, then yes, I would rather not operate on any such case, as I said, and try to wait until the pregnancy is dealt with. But if it is looking aggressive on the scan and the biopsy is suggestive of a renal cell cancer, then probably surgery will be the right thing.
Right. So there's one point from Zishan, a colleague from Dundee, that if the biopsy is not malignant, oncocytoma benign, we could make a case for Cysteamy B scan. So I personally don't know the value of Cysteamy B scan in that setup. Zubair, any comments on that?
Right. Again, we don't use it much often, right? In certain cases where you want to prove that oncocytoma is more kind of apparent and more diagnostic, some studies do show, or people advocate it. I personally hasn't had much experience of that, right, in my practice to date. But that's obviously something is emerging. Will it be safe in pregnancy, and can we really use it? I don't know, but that's certainly something can be debated upon.
Zishan, would you like to elaborate on this, the value of Cysteamy B scan?
Yeah, thank you, Prof. And thanks, Zubair. Very good talk. And I think you approached it really well, this case. Well done. Congratulations for that. I think Nazim has already made a point, which I think we need to clarify first about its safety in pregnancy. But speaking about Cysteamy scan, I think the data has been there for more than 5 years when first Johns Hopkins, Mohammed Alab's group had started it, and they had reasonable result. So it's a mitochondrial concentrating agent, which is, and this is used mostly for thyroid, which helps to differentiate between oncocytoma with malignant other malignant cancers, but it can cause a bit of confusion with chromophobe. So that would have been really tricky in this case because it's a chromophobe final pathology, if I understood correctly. And so it with biopsy, again, this is not accepted as a standard, or there are no guidelines on that. But if someone has biopsy which shows oncocytoma, and radiologically, if there is on CT scan, there is some features of oncocytoma, then I think a positive on Cysteamy B scan can provide some reassurance. I have done it in a few patients where we don't have much option of doing surgery. Biopsy suggests oncocytoma, and Cysteamy B scan suggests oncocytoma as well. So we are just following those patients up, but it just gives some added reassurance where our hands are really tight. I think over the next 5 years,
Thanks.
probably.
I think these are.
Yes.
Yeah. Great. So thank you very much, Zubair. I think this is really raised some important questions. Particularly, your cases were very nicely chosen. There was good questions and good interactive audience. I'm quite happy that our audience were really with us, and they made some very correct observation about management. We're coming to the end of this wonderful session, and I'm really grateful to Dr. Cheema from Shaukat Khanum and all our audience from all around the world, from Dundee to Karachi. The next conceptual basis of urology course will be on Saturday, 15th of January. This will be, our speaker will be Dr. Athanasios Papasaurus. He's professor of urology, and he's a big name in urolithiasis. He's the member of the ULIS group. He's also a member of the EAU on urolithiasis and also of World Congress of Endourology. So he will be, and he's a very good friend of mine for a very long time now. So Thanos will be speaking about disposable flexible ureteroscopes. There will be some case discussion, and I'm sure that we will have some good moderators for that session as well, or panelists, not moderator. I'll be moderating, but panelists from the stone people from India and from Dubai. So hope that you will join us again next Saturday. And then subsequently from February onwards, we're going to have our sessions on first and third Saturday. We couldn't do first Saturday because it was 1st of January. So thank you very much for being here tonight, and hope to see you again next Saturday. Until then, Khuda Hafiz.